Hello, and welcome to Embracing Diabetes, a podcast that explores the many ways people are thriving with diabetes in the world. I'm your co-host, Dr. Liz Stevens, and today Amy and I had a chance to talk to Dr. Eden Miller, an osteopathic board-certified family practitioner and CEO of Diabetes and Obesity Care, a medical practice in Bend, Oregon. I recently met Eden at the ADA meeting in San Diego and really appreciated her style and humor, and also learned she has spoken extensively in the field of diabetes to healthcare providers and patients alike, drawing on her life experience with type 1 diabetes, which she developed in medical school. During our conversation, we learn about her diabetes journey, why she chose osteopathic medicine, what she wishes more providers knew about living with diabetes, and her hopes for women leaders in the diabetes space. I hope you enjoy the conversation. Eden, thank you so much for making time to be with Amy and I on Embracing Diabetes. You and I met briefly at the ADA last month, and I really enjoyed your presentation there. And I know you probably did numerous things, we'll circle back to that. But we usually start our podcast hearing about people's life experience with diabetes. And I know you were diagnosed, I think, in medical school, which is the same as me. I was diagnosed my third year of medical school. And so I was curious if you could share kind of your diagnosis story as you feel comfortable, and how it affected just your sort of training time. I know for me, it was just like, it was important, but how was it for you?
Absolutely. Yeah, I think we're living a little bit of parallel lives, but at least a uniqueness. Lived my undergraduate collegiate life. I was blessed to be a 4-time All-American in track and field and the heptathlon and the javelin. And at a point in my career, I really made a change to go ahead and go into healthcare and kind of leave athletics behind. So I went in and enjoyed the rigors of med school. I always felt it to be a challenge that Sherlock Holmes taking apart cases was enjoyable, and met and married my physician husband. And we embarked on our very young married life and went up into the northern United States, up into the Michigan area, and only been married for maybe a few months. And starting around end of January, 1st of February, I was at my father-in-law's retirement party. He was a base commander in North Carolina for an Air Force base. And I remember being at his party and like almost passing out. And I thought that was weird. I'm the strong individual. And my husband said, "What's going on?" And didn't think much about it. And then about 10 days later, on Valentine's Day, that's your D-Day. My D-Day is Valentine's Day. Always seems to be holidays for people. I woke up and just didn't feel well and was talking to my preceptor, and that's our clinician leader who was a general surgeon at the time. I had just completed an inpatient pediatric rotation, which was interesting. Inpatient P is really rigorous, and you're immersed in all of the viral milieu. And on a Monday, I was out for a run. I had this epigastric kind of feeling, and I told the surgeon who I was working with, and he goes, "What do you mean? I feel like somebody's stabbing me." And lo and behold, he did some laboratory values on Monday, and I ended up having pancreatitis. And it was pretty interesting. I didn't have the typical like high cholesterol or anything like that, or stones or masses or anything. In fact, I was only taking birth control. I didn't even drink alcohol. I was a pretty clean gal, and just had this pretty fulminant pancreatitis. In fact, my glucose was normal on a Monday. And then a few days went by. I didn't eat anything, drank a lot of fluids. And on Sunday, driving to church, as we were driving, I told my husband, "That's funny. The signs are blurry." And as soon as I said that, we both looked at each other. And on that next Monday, I went in to the endocrinologist. She was at the hospital that we worked with, and my glucose was 400. And I remember taking my first shot of regular insulin at the time. Shows you it's been 28 years taking. And I thought my life was over. They did some other diagnostic tests. I ended up being a little bit of a variant, but that's for another podcast. I don't have antibodies. I don't have genetics, but I essentially do not produce insulin. And the rest of my pancreas recovered, but that portion didn't recover. My kids swear that upon my death, they're going to exhume my body and biopsy my pancreas and see if it produces any insulin. They're going to donate to science. They've already warned me. So I know that I'm just going to be stripped for parts to make the world a better place. But that's fine, all for the cause. But no, I think for me, the foundation or the pivotal point, we all have our diagnosis story, but it really ended up an inspirational story because I think I received the type of feedback and care a lot of our friends and colleagues and patients get is that, oh, you have type 1 diabetes, you're in the middle of med school. I was in my 4th year getting ready to go into internship. And they said, you might have to take a break, you might have to get away from medicine. I even had some individuals who were well-meaning. You might not be able to have kids, things that that's a big burden. They're essentially telling you your life as you know it is over. And they did the workup. And then to my benefit, I got referred to an endocrinologist by the name of Dr. Richard Levy in Ohio. And when I was referred to him, because I literally had my workup in Michigan, but they were all like, you're weird, you're atypical. And they sent me to Dr. Richard Levy, and I walked in and I remember sharing with him the same story I'm sharing with you. And he goes, oh, Eden, he goes, you need to decide whether you have diabetes or it's going to have you. He says, you can do whatever you want to do with your life and take diabetes wrong for the ride. And that changed my life because he was real. He says, it's going to be new. You're going to do great. But then there's going to be times that are going to be hard. He told me the things I'm going to struggle with. He goes, oh my gosh, have kids. You've had diabetes for what, 2 months? And lo and behold, we got pregnant like literally 6 weeks later and have been blessed with 2 kids. But I think besides it being a hope, he gave me hope. That foundation, because I was in primary care, that was the direction I went in my medical training. And I just found myself naturally wanting to help or assist people who had diabetes because it was our shared story. And I contemplated, because in family medicine, you really can't become an endocrinologist or specialist like cardiologist. That's called an internal medicine path. But in family medicine, we call it a jack of all trades. In other words, you know everything, but you're not necessarily a specialist. Rather, some would say we're specialists in everything, but it matters not. But I contemplated going back into school to do an internal medicine residency and then going the path of endocrinology. And I was like, oh gosh, that's a lot of training. And I had some endocrinologist friends of ours in the Northwest area who says, oh gosh, stay in primary care. We need diabetes experts in primary care. This is primary. And so who would have thought 20 some years later with that foundation of this amazing endocrinologist who gave me hope, who set me on that, I ended up through several open doors and getting additional training at different universities and just educating myself both personally and professionally. And so as a result of that, my motto is to turn patients into experts on their own disease and how to live with diabetes. And like I say, how to live the sweet life, taking it along for the ride. And so that is my story.
I really like that. And I think Liz and I have talked about this before about how some of those first conversations when you are newly diagnosed, how they really set the stage for the rest of your life, set the stage as far as how you feel about living with diabetes. And
For sure. Yeah.
I really like what your doctor said, that either you're going to have diabetes or it's going to have you, and taking it along for the ride. I like that.
And I totally agree with that. I think there's so many people are affected for such a long time by those first interactions. And I know Terry, who you've met in Hawaii, my girlfriend and I talk about how there are people out there in the world who, even though they don't have diabetes, they just really get it. And it sounds like your endocrinologist just got the chronicity of it and the need to take ownership of it as best you can, and being a part of a team and all of that kind of stuff. So so fortunate, because you could have gotten stuck with someone who was like shaming and awful.
Right. That's
a totally different journey.
Yeah. It also goes to the point of how words of hope and encouragement can be the foundation for a lifetime to build on. It didn't mean that he said that and then all my problems were solved, but rather I had such a firm foundation to go from there. And one of my things that I try to do, because as a physician and clinician, I'm blessed to be able to be in clinical practice, in family practice with a specialty in diabetes, but I can't see every person with diabetes. I can't do that. And so one of the things that I like to do as a part of my additional career is I am a professional educator for my colleagues. And that's anybody who's on the team. I've lectured to dentists. I'm going to talk to some neurologists. And in teaching them the science or the pathophysiology of diabetes, but also imparting that hope. Because one of the problems, as you said, is a chronic disease is that diabetes is like a 2-year-old that never stops crying. And you're just always trying, what am I going to do? Am I going to ignore it and become apathetic, and I'm going to engage in it? And it's how to keep that pace. And so that is what I've been blessed to do. And my kids asked me a question the other day that I just was, they're adult children, and I couldn't believe my thought about this. They said, Mom, with all the stuff that you've been able to do and impact the trajectory of diabetes in your life and others, would you go back and choose not to have diabetes? And I was like, whoa. And I had to pause because it's a serious question. It's a chronic condition that has its baggage and burdens with it. And I got to thinking about that and how it's shaped who I am, but it doesn't define me. You know what I mean? But it's been an opportunity. And I told him, I said, you know what? I don't think I would, because it's gone from this struggle to a blessing. And that's life anyway, right? You have struggles and conflicts. And so you can either be a survivor, post-traumatic growth versus post-traumatic suffering. And so that's what I like to do. I like to do it for myself and then encourage each other, because we do need that encouragement and we need that accountability as well, because there are times I fall off the wagon and my patients will say to me, hey, you need to get back on this, and we're all in it together.
I'm curious too, like, one of the things I think would be helpful for this is a bit of not a smooth path, but tell me about osteopathic medical school. Like, tell me why you decided to go down that route. And because I think a lot of people don't really understand the difference, DO versus MD and that kind of thing.
Yeah. So my husband has a very different exclamation of it. And he always cringes when I do that, because he works at a high level with the DO community in the United States. But I always start like this. I said, we have two kinds of politicians, right? They're different groups and different opinions, but yet they both serve in Congress. They both do different things like that. And I always use that analogy. And we really have two schools of medicine. They're both board certified. They're in all specialties. There's really no difference in terms of how the roles they fill. In fact, some of our U.S. Surgeon Generals have been osteopaths. The head of the military army medical was a DO, and that distinction is called Doctor of Osteopathy versus MD being medical doctor. Now, I think there's one misnomer that happens as being called a DO is they all think we're bone doctors because we have the word osteopathy. And really, it comes from our history of being founded by an MD named A.T. Still, who was in Missouri at the time. The medical school I went to is actually older than Harvard Medical School. A lot of people think it's a relatively new. It's actually, we're an older. And also, the osteopathic school was the very first school to admit women into medicine, which I didn't know that in the past. And so really, to boil it down to is the MD and DO world. What's the difference? And I think the difference is maybe the founding philosophy. We were at a very early time in the school, we learned about what's called mind, body, and spirit. And it was the three components of medicine. And at the time, medicine was an emerging thing. It was still in its infancy in terms of science-based stuff. And so AT Still said, hey, we have a body that has all these parts and organs and bones and skin, and they have to play a role. And so he came at it from a different perspective, I think. Now we see a lot of congruity. Now the allopathic or MD world has a lot of that as well. And maybe it's merging together. Many schools, MDs and DOs are together, which is silly because they're both there. But what do they separate for? They separate for what we call manual medicine, which is we do hands-on medicine. We know anatomy maybe a little bit more than our MD counterparts, but I feel bad to even say that. I think it's just really our training. And we have a different set of tools that comes to the table. I will tell you from more of a demographic standpoint, DOs tend to train more family practice. I think that's just our legacy. It's not that it has to be that particular track. You could be a cardiologist or a dermatologist, but it's just a little different flavor. And I think it's great. It creates that variety. And depending on where you're at in the country, if you're on the East Coast, there's a high number of DOs or osteopaths. West Coast, maybe not as many. And so it's just really more of a regional thing.
That's great. Thank you for explaining that. Because I think in the residency program that I work in, it's probably half DO, half MD. Yeah. And I remember in residency training, we had a number of DOs, and the manual medicine that they would do was often very beneficial for patients and adjustments. And it was really great, even for us.
You got to benefit.
You get like your adjustment.
Just another tool, which is great.
Yeah. And so one of the other questions that I had for you was, you're so articulate about your kind of passion for living with diabetes and helping people with chronic illness, just sharing your experience. What is one thing, I mean, I've thought about this a lot too. What is one thing that you wish more medical people knew about living with chronic disease or living with diabetes as they work? Because like you said, we can't see everybody. You do a lot of advocacy for our community and education. And so you see, especially in places like dentists, neurologists, things like that, where they have really, or God, for like ophthalmologists, or just they're often pretty uninformed.
Yeah. I think it has
to,
I think it has to do with the roots of maybe diabetes in its infancy. We didn't really have a lot of therapies for it. So as a result of that, it became a chronic disease that we weren't very successful in. But if I had to boil it down to this, it would be shame and blame. I often start out some of my lectures, which, as you can tell, I have a little bit of spice to my presentation. And so I will talk about how diabetes is not very sexy disease. That when a person gets diabetes, like nobody brings you a casserole. They don't say, "Oh, I heard you have diabetes. I'm so sorry. Can I bring you a casserole?" Right? Other diseases such as cancer or different things like that, it tends to have a little bit more empathy with it. You know what I mean? And I hate to say it, but it's true. And so when you do see some engagement with different clinicians, and again, they all come from different backgrounds, but if I could inspire them, I would say, understand this is a chronic disease that you live a long time with your life. And yes, it is a disease, fortunately, that lifestyle intervention can impact, but it's not as a result of that. It's not like, well, you're a smoker and you got cancer. And I think that to break that barrier or that inertia that we all have, I think will go a long way, because really individuals are just wanting information. I've worked with the ADA in a committee called Overcoming Therapeutic Inertia, which is looking at the barriers patients have, the barriers prescribers or physicians have. And I did an unofficial survey that I haven't published. I'll have to publish it because I'm going on record. But we asked persons with diabetes across the country what their number one barrier was. And then we asked all the prescribers what they answered as the patients. And the number one barrier that was provided by persons with diabetes of all different backgrounds was fear of the complications related to their disease. And I thought, oh my gosh, they are not articulating that to us, because it's very intimate and it's very personal and they feel shamed. And so they can't have that opportunity. And so one of the things I do to try and overcome those is when a person comes in, I say, "Hey, how you doing? Good to see you. Tell me one of the things that you're really finding a hard time to get past your diabetes today. I really want to make sure we address that today." And then I end with something, really want to just commend you and what you're doing. Your A1C stayed the same or your weight staying the same. Always find something positive, because they got to get back into the game again. And then my final thing is for prescribers or healthcare providers out there. And this is what I'm also passionate about. If you come across an individual who is very unengaged, we use lots of different words, non-compliant, apathetic, a lot of shame, but unengaged in their disease, I promise you that's a very distressed, very sad, very hopeless individual. And that is your opportunity as a prescriber to intervene and say, "How you doing? Can I help you with something? Can I lessen the burden? Can we look at something that'll make it easier to live with it?" And if I could get all my colleagues to do that, I think we'd see a community that's a lot more healthier and a lot more ready to keep their disease for that whole lifetime of care.
That's so inspiring to hear. And it makes me reassured to know that you're out there advocating for that message, because I know Liz does it every day with her patients, but sometimes it feels like change is happening so slowly. You can inform one person at a time, but you, Eden, have a big stage, which is fantastic, because I see it as something that's achievable, where you have all of these people in diabetes distress and who have given up and who don't have hope. And I feel like it's so easy to just change a few conversations or to give that hope back.
Yeah.
And which makes a lifetime of difference.
Totally. Yeah. Small steps. Talking with everybody who touches into people's life experience is really helpful. Yeah. And then I was also curious, because you and I met Eden at the ADA, like I said earlier, and it was at the Women and Leadership panel that you did with those two other women. And I was just curious, like, where Amy and I have a real interest in working with women and advocating for women. And I think probably a fair number of the people that listen to this podcast are women. And What are your thoughts about how to get more leadership for women in the ADA or I'm not ADA, any diabetes community? What are
Yeah.
your thoughts about
Yeah.
that? Yeah.
It was an honor I got invited to be part of the panel, and the Women in Medicine type ADA network is relatively new. It's only been around for a few years. I think COVID slowed it down a little bit just because we all were rubbing elbows and getting together. And was a reminder and an inspiration of the opportunity to encourage women, and really thought about, but prior to being honored in this manner to be an encourager, is like, what kind of message did I have? And one of the messages is, I think pride and confidence. As women, we are unique. And I know in a societal age that we want to make sure that everybody gets a fair share, which I'm always for that equal opportunity. But at the same time, I feel good about myself as a woman and as how unique it is in my relationship with patients, which is different, being able to see my physician husband interact differently. And so with that, with women, we do have a special, I think, medical nurturing opportunity and an encouraging opportunity. We are a verbal group of gals, and I think more ways in sharing and talking. I think when you become a woman profession, one of the things, the stigma I want to break is that, a really good woman profession is an isolationist. She doesn't need anybody. She doesn't need to talk to anybody or have any cracks in her armor. And I think that's one thing we need to start doing, because we are a powerful force of us gals getting together and tackling these challenges. I think the wisdom that I have for younger women professionals, or even women who are interested in just being somebody living with diabetes and empowering their life, is to set a pace you can keep for the rest of your life and make sure that you don't feel like you have to accomplish it all by 30, or also having a mission statement. That's something that I really, in the last 10 and 15 years, because of having some great opportunities and success, I had to learn to be choosy about what I did and learning the power of no. But instead of just saying no, you can say, oh, thank you so much, but I really have been focusing my energies here. This is what I've been working on. And if that ever comes back, I'll circle back around to you, or coming up with another individual to say, hey, do you have I have a recommendation for somebody who can do this. And so I think knowing your mission statement, and that can be many things based on what's my mission statement as a person with diabetes, what's my mission statement and the different components, and what is my career and how do I want to accomplish that, and being very purposeful. Sometimes you say, oh, I want to do better with my diabetes. Oh gosh, that's like really broad. Let's pick something you want to do. I want to work on policing before meals, or I want to work on good food choices, and being purposeful about those things and setting attainable goals and then celebrating them. Because so much we forget to do the atta girls. And so I think if we do it individually as women with our goals and our mission statement, and then come together and collaborate, because that collaboration is energizing, just like this. And it also means we don't have to do it in a vacuum. We do it as a group. And with that herd of us, as we can conquer things, and then we can give each other advice, do different things. And I think that's going to be more interactions, whether it's virtual like this or podcasts, or I'd love to have coffee talk sometime or cocktail talk, or whatever we feel to do, and do it in just a manner of encouraging and building each other up.
Did you have, when you were moving through your career, because it sounds like mentorship is a big part of what you're describing also. Did you have mentors that were helpful for you, or people that were inspirational that kind of helped?
I think I had drive-by mentors, which in our fast-paced world, there's just the drive-through, drive-by. But I think of a couple endocrinologists, one in the Portland area who's in Providence, who just was quite encouraging to me. Just sometimes a few lines of saying, as you can tell, I had these kind of one-liners that I've been building my foundation on. I've had quite a bit of gentlemen, professional gentlemen, who, as I got invited to the table as a woman, as a young woman, I could see looking around, I was honored and realized that I had been placed in a very unique spot. And with that, I was listened quite a bit. And so in listening, then I gave my feedback. And I think for me, that was for my secret of success, is I had a lot of endorsement from the medical community. And I had my barriers that we all have to overcome. But I think having women who just were very confident. And, I think that calm, peaceful confidence has a lot more than go get up kind of thing. But that's just me. And so I have some that I think of. And at the same time, I feel eternally blessed to be able to then turn around and encourage the next generation, because we want this to be a moving, living thing and in all directions, right? And so that's what's exciting about that opportunity.
Awesome. We're getting close to time because usually we try to keep these like 20, 30 minutes or what have you. So what are some things, Eden, that you're excited about? What are some kind of upcoming things you're hopeful for?
Sure. It's a good time to have diabetes. It really is. I can say that if there's one thing that's going to propel us into the future to lessen the burden of care, improve our outcome, and as I often say, let us forget that we have diabetes, at least for a moment, is technology. And we've all experienced it, looking at another device that can track you while you can just let your brain live a little bit. So the world of continuous glucose monitoring for me has taken diabetes from 30,000 foot view to a microscopic individual GPS. And so I'm quite excited to be honored to work in that field, because it really is the great equalizer where we now can view diabetes through a lens that not only is microscopic, but it's also so individualized. We're learning so much about how food affects people, stress affects people, different medications have their own little CGM fingerprint. And so for me, it's a good day. I think then pairing that with the insulin delivery devices from a automated standpoint, either partial or completely closed loop hybrid in the future, will alleviate that. And then going beyond that and looking into what we call those comorbidities, which is the fancy term for the effects of diabetes beyond glycemia. I think we're really starting to get that focus of how to live a healthy life, how to do that. And then I think what naturally occurs about that is we have less of an emotional burden with it. But I still think there is a lot of movement needed in the world of mental health for people who specialize with diabetes, who understand that, right? We have a gap. That doesn't mean gap is not bad. It's an opportunity. And so I do think that there are some things coming. I think the most excited thing I'm personally working on, and I'll end with that, is my husband and I, which we're a duo. It's been a joy to work with him. Who can say you work with your husband for 27 years in medicine? It's a great honor, and we've kept that great relationship. And what we're doing is we're redefining what we call pre-diabetes. And I may be letting the cat out of the bag a bit, but we don't believe there is a condition of pre-diabetes. It's like being pre-pregnant. You can't have that state. And we know that at least in the field of metabolic diabetes, what we call type 2 diabetes, that it also has its variants. We have a staggering number of people in the United States at 96 million and over 400 million in the world. And there's many reasons for that. It's not just lifestyle. It's a lot of change in society and genetics. And we have an opportunity to identify those people and intervene. And so what we're doing quite innovatively is we're redefining early diabetes into stage 1 and stage 2 early diabetes type 2 and working with the ADA. And I think there's an interesting dichotomy that comes with that. And one of the reticent of the consensus panel at the ADA is, do we want to label 100 million people with diabetes tomorrow morning? And that's not the issue. We're not talking about labels. We're talking about knowledge and empowerment and prevention, because they're there. And as I mentioned to some of the thought leaders, we're not incorrect at our assessment of what is happening with metabolism and type 2 diabetes. It's just a hard message. And how are we going to make that message that identifies and empowers people to actually, in one field of diabetes, prevent it? Because that's really what we need to do. We need to start preventative medicine. So you can see I get excited, busy, I'm encouraged, and I so appreciate this opportunity to circle back around and chat with you and with our listeners and encourage them in their day-to-day lives.
Thank you so much, Eden. I hope that you can send some resources for us to include in our show notes, because I feel like there are many things that you have talked about throughout the episode that I want to make sure we can point people in that direction.
Yeah, absolutely.
That would be great. Yeah. And thank you so much for making time to talk with us. And it's so great to have you as a colleague in the fine state of Oregon, and just all the advocacy work that you're doing and being such a strong female voice out there.
Yes.
For our community and just taking care of people, because primary care it's really important.
Diabetes is primary.
Yeah.
And I appreciate this opportunity, but I'm going to hold you to it. I want our coffee talk sometime so we can get back around together and just commune with each other.
Thanks, Eden.
Thanks, Eden. Take care.
Thanks. Bye.
Thank you for listening to this episode of Embracing Diabetes with your podcast hosts, Dr. Liz Stevens and myself, Amy Stockwell, and music by Noah Mortola. We hope you enjoyed the conversation and maybe felt inspired or informed or less alone or all of the above. Please follow Embracing Diabetes on all major podcast platforms and leave a comment, question, or review. Thanks again. We hope you'll come back for more.